practiced gerontological nursing and a PhD in nursing. She is currently the assistant professor and director of outreach, recruitment, and education at the Latent Aging and Alzheimer's Disease Center at OHSU. She's authored original research books, book chapters, posters, abstracts, as well as served as a reviewer on dozens of geriatric topics. Her main area of scholarly interest is dementia and the care for persons with dementia, and that's going to be the subject of her talk today, the new normal or the new abnormal, making sense of cognitive changes. Dr. Lindauer.
Thank you so much. Good morning, everybody. I'm delighted to kick off the year of Grand Rounds. A little bit nervous, but delighted. Can you hear me okay? Okay. If you can't, give me a wave. I have kind of a small voice. Like Dr. Powers said, I'm at the Latent Aging and Alzheimer's Disease Center, and I do a couple of things there. I do research with families who take care of family members with dementia using technology. I also see patients in our clinic for dementia. And then as Dr. Powers said, I'm director of the outreach, recruitment, and education arm at the center. Let's see here. We got to get this to go. There we go. So the Latent Center is one of 30 NIH-funded Alzheimer's disease centers around the nation under the auspices of the National Institutes on Aging. We've been funded remarkably for about 20 years. And I was telling Dr. Powers that the funding started from a family, the Latent family, Ruth and Rex. They gave us the seed money about 20 years ago and still are very active in the center. So at the Latent Center, we do research, which I'll be telling you about. We do clinical care and family support. We engage with the other 30 sites around the nation to identify the best treatments, learn about cutting-edge findings, collaborate on a number of projects, and that includes longitudinal studies where we collect data to learn about how people age and memory over time. So one of the things that occurs in my work is I meet a lot of stressed out families, and I'm sure you do too. So what I did was I designed this talk to kind of help you deal in an efficient way with families who are struggling with memory changes or are worried about memory changes. If you're a gerontologist in the audience, this might be a bit boring for you, but you get coffee, so feel free to leave. But if not, I'm glad you're here. So we'll talk about normal aging very briefly, cognitive function, and then some steps for you that are very practical for your day-to-day work. So the first question, of course, is what is normal? Let's start with the brain first. One of the things that we do know is normal is that as we get older, the brain tends to shrink over time. So starting at about age 40, we lose a tiny % of our brain every year. So that's the bad news. The good news is that the brain compensates, the brain adjusts. It can adapt. For people who have Alzheimer's, however, the rate of shrinkage is much faster. And in my world, we spend a lot of time worrying about the hippocampus because that's kind of the center of the brain where memory is stored. Of course, there are other areas, the cortex, frontal lobe, and all of that, but we get really hung up on the hippocampus. This slide shows what I was talking about a second ago, in that the brain does shrink, I don't know if I have a pointer, over time, and that's normal. So these blue dots are normal. But for people with Alzheimer's disease, the brain shrinkage is much faster, and that's because the Alzheimer's pathology kills nerve cells and causes brain shrinkage. I like to think about cognitive function, whether normal or abnormal, is in this kind of Venn diagram. This is only a diagram, it's not perfect, but it does help me think about memory and cognitive function. So normal memory involves a variety of components, including working memory, where we find the right parking place and got myself here and found the right room, calculating a tip, those kinds of things. Semantic memory is memory for knowledge. Those of us, for example, in dementia care will always know what a normal cognitive test result would be. Episodic memory is memory for important life episodes, biographical episodes, weddings, funerals, graduations. And executive function is technically not a memory. In fact, the literature is kind of confused as where to classify it, so they just put it in the memory diagram. But it's essentially the supervisor in your brain that helps you make good decisions. And then on top of that, we have processing speed, how quickly we can process information and attention. As we get older, our processing speed does slow down, and that's normal. It should slow down a little bit, but not a great deal. A good example, I have a teenage daughter. We take a dance class together. The teacher said something like, I want you to do these certain steps across the room. And I'm kind of trying to figure it out. Both my daughter and I have been dancing all our lives, and so she's halfway across the floor, and I'm still trying to put it together. And that's normal. But there's also the factor of attention. So if we're in that room and I got a page or my cell phone went off, then my attention's just distracted me, and then I can't attend to what's going on. All of this, there's a subtle change as we get older, but it's really not a profound change. When it's a profound change, that's when we get worried. For example, most of us will remember those important events in our lives, our weddings, important funerals. A person that can't remember those, that's worrisome. A person who can't remember their spouse's face, that's concerning. I'll get a little bit more deeper into this in a minute. The main message that I want to convey is that when you do see a change that's concerning, do pay attention and address it. Oftentimes in our clinic, we'll have families who come in and say things like, well, I thought I told my doctor that I was worried, but he hid a quarter across the room and asked my mom to find it, and she found it and said she was okay. And I think that's a rare occurrence, and I think it's partly that families are stressed out and trying to make sense of it all. But if there is a family concern, if families are worried, that's a red flag. The other red flag is if you see personality changes. So if a person that's normally a little bit neurotic, who's kind of flat and doesn't care, that's worrisome. It doesn't mean they have dementia. It just means that there's something that needs to be explored. The Alzheimer's Association gives us some guidance, and this is something I use with the families and the people that I work with quite a bit. And I don't know if people ever come up to you and say, hey, I keep losing my keys. Do I have dementia? Do people do that with you? Yeah? And I know that that's a concern because dementia is so common. It affects, 1 in 10 people over the age of 65. So it's a very real worry. So I like using this information to help talk them through and talk them down a little bit. So the concerning changes, poor judgment, consistently poor judgment, spending a lot of money, for example, at yard sales. I see that sometimes where people usually have fairly good control over their money, and then suddenly they're spending a lot on a consistent basis. Making a bad purchase once in a while, we all do that. But when you see a consistent pattern of poor judgment, inability to manage a budget, some people don't manage their budgets anyway, but they should kind of have a general idea of how much money they have and how much they can spend. Everybody, I would hope, misses a monthly payment now and then, but it shouldn't be a regular occurrence. And that is also something we see in the clinic. A daughter or son will bring their parent in and say, I just discovered all these bills that she hadn't been paid and her electricity got cut off. So you can see that pattern of not paying a lot, whereas now and then that's normal. Losing track of the season. is also very concerning. Now, in Portland, it is hard to tell if it's fall or winter. I grant that. But for the most part, people usually know what season it is. We often will forget what day it is, and that's normal. You remember later, and that's okay. But when people forget what season it is, that's worrisome. I've had people in clinic who it's a hot summer day, and I'll ask them, what season are we in? And they'll say fall. And that's a red flag. Difficulty having a conversation. So I'm sure you've met people who will tell you the same story over and over again in the same conversation. That's a sign that their memory isn't serving them very well. And so they aren't tracking or remembering that they already said that. The other thing we'll find are difficulty finding the right word. Now, we all have some trouble now and then finding the right word, but on a consistent pattern. Again, we're looking at patterns and consistency. Sometimes forgetting what word to use is normal. And then misplacing things and being unable to retrace your steps. Has anybody worked with somebody who has dementia and they're convinced that their purse has been stolen? Yeah. So that's what I mean. They can't figure out why they can't find their purse, so they jump to the first thing they can think of as somebody must have taken it. For those of us who lose things a lot, we can retrace our steps. So I lose my keys. I think, well, so I drove yesterday, so it's either in my coat pocket, my purse pocket, on the hook, or the dog has it. There's I can think about all the things where it might have been, and then I go and look for it. So when people say, hey, I keep losing my keys, your next question should be, well, do you know where to look? And if they say yes, then you can reassure them. If they say, no, it's usually that my son stole them, then that's worrisome. Does that make sense? Okay. So then people will ask you, should I worry? And when people have memory trouble, it could be a lot of things. We all know it could be a depression. We all know people who've a family member or somebody they've been close to has recently died, and their heads just kind of mixed up. That's normal. But it could mean a mild cognitive impairment, or it could be even dementia and a number of other things. This is a very simplistic list. But I would like to talk about mild cognitive impairment, because this is kind of where the money is these days. First of all, this is a real diagnosis. It's not just a term we made up. It's a diagnosis that identifies some significant change in memory that has changed compared to previous abilities, and yet the person who has mild cognitive impairment, or MCI, has preserved function. So that's why that's yellow, italicized, and underlined. That's the main point there. So for example, they may have a little trouble in all these domains, but they can still drive, really can still drive, go to the store, attend to work. They just have some deficits. They're aware of their deficits, and they compensate for their deficits. Most commonly, we see MCI in people, the domain we most see is memory. So people will have a really bad short-term memory that's pathological, not just normal aging. But everything else will be really intact, and they'll be able to function really well and normally. So I have an example, but I'll just run through this. MCI is very common. A lot of people over the age of 65 have mild cognitive impairment. What's concerning is almost 40% of those people will convert to a dementia about 5 years later. So the risk for dementia in MCI is real, and it's there. And it's also where we see the opportunity for action to either delay or prevent the progression to dementia. And I'll talk about that in a minute. So here's a good case for you. 73-year-old, semi-retired physician reports that her memory is terrible. I mean, I think we all feel every once in a while our memory is terrible, but she continues to be active. She goes to medical lectures. She does occasional exams for insurance companies. She goes to yoga. She manages her medications without any trouble, and she can use her cell phone very easily. She travels with her husband and hasn't gotten lost or disoriented. Husband corroborates. Now, this is really important. Whenever you see somebody in your practice who has memory trouble, there must be somebody else there with you, with that person, a daughter, a son, a husband, a spouse. Because a lot of times, people with memory trouble don't recognize that they have memory trouble. And it can be a bit tricky. And we'll talk about this a little later, too, how to navigate that. But my own father had dementia. And about 6 months before he died, if we had taken him to his PCP and sat him down, she'd say, Ken, how's your memory? And he's like, well, hell, it's just fine. And my sister and I would do what our team calls the laid back sign, where you lean back in your chair and just say, no, he's not fine. And I think that's very common. And so when we see people in our clinic, we insist that they bring somebody to validate what's going on. So in this case, the husband's like, well, she has some senior moments, but he doesn't think it's getting worse, but her hearing is horrible. This is frustrating for everybody, and she just scoffs at it. You just need to speak louder. So as you know, we do a general workup, the labs, the MRI. We use the Montreal Cognitive Assessment. Does anybody use that? Okay, we'll go through that too. And so this woman scored lost 2 points on short-term memory. So we give 5 words. We ask them to remember those words at the end. She was not able to do 2 of them. She missed 1 on letter identification and 1 on serial 7. So letter identification is, I'm going to read you a long list of letters. Every time you hear the letter A, I want you to pat the desk. And then serial 7s, you probably all know, starting with the number 100, count down by 7s. And her brain showed some smidge of atrophy. Hippocampi were normal. So talking about the opportunity for action, I blatantly lifted this from Stahl's Essential Psychopharmacology because I love this graphic. Most of the time when we diagnose somebody with dementia is at the tail end of when the brain changes. So oftentimes a person will start having changes in their brain very early on, maybe 20 years even before the dementia. And then we'll see some MCI. They won't have any symptoms, but when MCI and those people who do convert to dementia does tend to start fairly early. And it's here where the research is really taking off, because we're recognizing that we need to target amyloid in the brain early. Just like, remember back before we start giving lipid-lowering agents to reduce cholesterol burden to prevent heart attacks, is kind of the same idea. What we know about Alzheimer's disease is that the brain cells die due to abnormal proteins. One of the big concerns is amyloid. Now, we all have amyloid in our brains. It's a protein. And amyloid seems to have some benefit. For example, controlling cholesterol. There seems to be something about vascular protection. So there is some benefit to it. However, in Alzheimer's disease, there's a problem with the manufacture and storage of amyloid, and so toxic amyloid builds up in the brain and kills the cells. And that's the amyloid theory of Alzheimer's disease, and that's where we are trying to get in and prevent people's from progressing to dementia. There's also the tau theory, same idea, abnormal cells causing cell damage. We're starting to do some research around protecting people from tau damage. So as you see here, this is where we really want to get in and protect people's brains. And these are the trials. Now, I know when I signed up to do this lecture, I said I'm not going to promote anything or whatever, but I'm not trying to sell this. I'm just giving you the information. And I don't care if you join us or not, but I thought you might want to know about some of the studies that we are doing. The APPV study, has anybody heard of the APPV study? It's a nationwide, study that targets that amyloid, that toxic protein we were talking about. We are currently recruiting for the APPV study, and people who get in the study can have a PET scan, and what the PET scan does show is the burden of amyloid. So people who have a higher burden of amyloid are at higher risk for developing dementia, and we do give them their results. In some studies, we don't. So it's kind of a leap of faith, but I think that the drug companies have learned that people really want to know their results. So that's good news. The other one is generations 2, and this one, they have to be amyloid positive, and this one is an anti-amyloid study as well. Now, I'm shuffling my papers because I have, I don't see, oh, this guy right here. If you have any questions or you want to talk to me afterwards, or you're not sure if you're interested in a study, this flyer out in the front has our phone number and our contact info. My business card is also out there, and my email and my phone number is on the slide set. So if you want to reach us, just let me know. Happy to talk with you. Let's see. We're doing a variety of studies as well. There's an MRI study, just looking at the brain, where you sleep in an MRI scanner overnight. And the one study that, I know, doesn't that sound horrible? It's amazing what gets funded, right? The other study that I do need a little bit help with is really interesting. It's called iConnect, and it's funded, our primary investigator is Hiroka Dodge. I don't know if you know her, but she's a world-renowned biostatistician, and she's starting this program where she connects with isolated older adults and has her team meet with them via telehealth to connect with them and see if that affects their memory. The study does give them a computer and gets them all set up. The people don't have to have a computer. So if you know of anybody who's having trouble, feeling a little bit isolated, please give them this. You don't have to know if they fit the study. Our team will figure that out, but I have flyers for that. So, okay, moving right along. Okay, woo, we got to hurry up. So let's talk about dementia for a minute. Unfortunately, there's still a lot of stigma around dementia. And, you know, I thought we were beyond that, but we're not. My assistant goes to various communities, and one person came up to her and said, you know, I really like the Latent Center, but your banner across your table says Alzheimer's, and people are not going to walk up to your table because they don't want to be associated with Alzheimer's, which is really sad, but there you go. And because of the stigma, we don't diagnose people, either because they don't come to us or because it's just too threatening. So about 50% of people who have a dementia do not know it. And that's a big problem because then they can't take part in studies, their families don't get support. It's really problematic. And one of the reasons is there's this idea of therapeutic nihilism. Well, there's nothing we can do, so why diagnose? But I'm going to give you some suggestions. Again, big problem, 65,000 Oregonians. In my world, what really worries me are the caregivers. I don't know if you can see this, but there are 184,000 caregivers for people with dementia in Oregon alone. Value of their unpaid care in 1 year is $2.6 billion in Oregon. That's B as in boy. That's a lot of money. So my work really focuses on supporting the family. I don't know if you get this question, what's the difference between Alzheimer's and dementia? I put this slide up just so you can remind the people that ask you this question that dementia is the umbrella term and Alzheimer's is a type. Our talk today really focuses on Alzheimer's, but there are a number of dementias, and if you have specific questions, I'll take a stab at answering them about other dementias. I love this paper. If you haven't had a chance to read it, it talks a great deal about the metaphors around dementia, a scourge, a dread, a tsunami, a crisis. None of this really helps us get to the people that need our help. And again, diagnosis is a problem. In the United States, this meta-analysis found that about 60% of people with a diagnosis with dementia were not diagnosed. But man, we're doing better than Canada. Look at that, 70% are Asian. So it's a problem. You probably already know the criteria. Cognitive impairment, which interferes with ability to function. Now remember, with MCI, people can function, right? But the dementia, people have trouble functioning in a normal way. It's a decline from their previous level, not explained by delirium, and then there are several other domains where we try to figure out what else is going on. So here's an example. 7-year-old lawyer, cognitive changes over 3 years, very gradual, does some volunteer work, complains of feeling forgetful and easily overwhelmed, and he's being treated for depression and anxiety. Sometimes depression makes dementia worse. Sometimes depression is confused, or the symptoms look like dementia. And recently, we're starting to wonder if maybe depression isn't a prodromal sign of impending dementia. So they often go hand in hand. And of course, the depression needs to be treated. Lots of questions from the person, calls his son frequently to give unwanted financial advice. His cognitive score is 18 out of a normal 30. So this person is concerning and most likely has a diagnosis of Alzheimer's disease. So now I'm going to give you some steps. When you're in a busy clinic, and when I used to work in internal medicine at OHSU before I went to memory care, and boy, that's a busy, busy clinic. And so I like to see people with memory worries the first part of my day when I have some energy. So make sure that you talk with your scheduling team to make sure that they know if there's a memory concern and make sure they get them in at a time slot that works well for you. They must have a family member with a friend or a friend with the assessment. There's some tools here for you that I'm going to go through. And when you bill based on time so you can get reimbursed as best as possible. And then there's also this G code that the Alzheimer's Association is promoting that's a comprehensive visit. And again, if you get the slide set, it has the link there for you. So this is Spade. Has anybody heard of Spade, the state plan for Alzheimer's disease in Oregon? It's a coalition of specialists that got together, even family members, decided, okay, what is important? What do people need to know? And how are we going to increase the diagnostic rates? This is a snapshot of the website. This is a clinical provider roadmap. So if you're feeling a little awkward about diagnosing dementia, or you have somebody with memory trouble and you're worried, just pull this off the Spado website and it'll guide you through each step, including the diagnostics and the follow-up plan. It also includes information about how to support families. So for example, The Help Is Here, a book that your colleague Marion Hodges and Ann Hill wrote, very helpful resource. The Alzheimer's Association helpline, also very helpful, and other resources. So if you're pushed for time, just go to the roadmap and follow the steps. If you have somebody that's younger than 65, or their dementia seems to be going pretty quickly, like you see them in January and in March, their scores are even worse and their behaviors are worse, that's concerning. Or they're a danger to self and others. They either need to go to the ER, or if you think it's fairly stable, definitely get them to a neurologist. At OHSU, at the memory clinic, we have a policy that I'm trying to change. We will see people with memory disorders if they've already seen a neurologist in the community. That's because our backlog was so bad. It's getting better. We have a new neurologist. She's an associate professor from UC Irvine, came up with us. Her name's Amy Pierce. She's terrific. She's giving a talk. This flyer is out front, so if you want to meet her, we'd love for you to come. But definitely refer these people. And then put the families to work. When somebody calls your office and says, I need an appointment, I'm worried about my mom's memory, send them to the Alzheimer's Association website and have them fill out the 88. This screening interview will give you some guidance and collect the information you need so you don't have to ask each question at that visit. So the family members will note if there's trouble learning or forgets the correct month or year. Remember those concerning signs versus normal signs, this really gets to that. And then this is the Montreal Cognitive Assessment. This is what I was talking about earlier. When you have somebody you're worried about, we recommend using the MOCA. The reason being is because the National Alzheimer's Coordinating Center uses the MOCA now. And it gives you a lot of really great information as you go through it. So our lady, if you remember, we had a lady, 73 years old, who lost points on the MOCA. She lost points here, like I was telling you about the word identification. Now that could be that she has attention problems, or it could be her hearing. And then she also lost words on short-term memory. So the MOCA is found online at mocatest.org. It's free, and it's in 30 languages. I administered the MOCA yesterday in Korean. I don't speak Korean. I had an interpreter, but it is possible to do. This is the Alzheimer's Association Direct Connect. So one of the factors that I deal with in my work, and I have time for, is talking with families who are stressed or distressed or worried. And so I usually have time, but I always connect them with the Alzheimer's Association because there are activities, support groups, you name it, they'll help you. On this form, all you have to do is the date, the name, and a phone number. I mean, you can put all the other details as well, but as long as they have a phone number, and then you ask the family member, hey, can I send this over to the Alzheimer's Association on your behalf? If they say yes, you click this box and fax it over. The fax number is right here. They'll take it from there. These forms are out front for you. Take as many as you want. The Family Caregiver Support Program is a Multnomah County program that provides support to family caregivers and some relief funds. This is in every county in the state, and they're a wonderful resource. They are not specific to dementia, but they're happy to help. So let's talk about modifying some risk factors. So let's say you have this lady who has mild cognitive impairment, or you have this person with dementia. How do you help them deal with the fear and take some control? That's what modifying the risk factors involve. So address the main culprits. This is very important for anybody, actually anybody, right? We want to keep blood pressure under control. We want to keep tight control of diabetes. We want the cholesterol controlled and control depression and alcohol use. Let's see. I'm missing a slide. I'm hoping it'll come to it. We know that about 35% of dementia is a result of risk factors that we can control. So hypertension, diabetes, high cholesterol. 9% of those causes of dementia that control is attributed to hearing loss. This is a big issue. We're not entirely sure why. It may be that people just can't hear and so they don't remember. It may be an extra strain on the brain, but that's a big issue. And then social isolation contributes about 2%. That's why we're doing this study with the iConnect. Hopefully I'll come to that slide and give you some more specifics, but definitely hit these guys. It's a little bit tricky, isn't it? Because if you have an older person with high blood pressure, you don't want to be too aggressive and make them hypotensive and have them fall. But if it's a younger person, definitely address that. In our practice, we often hear of a case where a person kind of falls into the classic dementia. They have some trouble on their cognitive tests. And oh, by the way, she drinks 3 bourbons at night. And it's fascinating to me that comes out, and I don't know why our neurologists are able to tease that out. I think they just ask. So please ask and get that really specific information. We all know that high amounts of alcohol use can contribute to a Wernicke's type dementia, and we may see that, and we have. But we also know that even if it doesn't, those people that are drinking are at higher risk for falls and certainly can cause some cloudiness and confusion. So if you have somebody that's drinking a lot, use your motivational interviewing tactics and try to get that down a little bit. we know about alcohol and dementia is that a glass of alcohol for women, one drink a day, and I think it's about 2 for men. We don't know if it maybe helps prevent a little bit. There are some studies that found that it's harmful. What we tell people is if they drink in moderation, that's fine, but don't start drinking alcohol to try to prevent dementia. This is just a screen you can use. I'll leave it in my slide set. You can go through all these questions, or you can just ask. It's really remarkable. You know, one person said, "Oh, I drink a bottle of Russian wine a day." I was like, "Well, what's Russian wine?" And our neurologist didn't ask. I can only speculate. And then these guys, these are easy, and these tactics give people a sense of control. So, hearing. We know that hearing loss is associated with lower cognitive scores, like Our Lady who couldn't hear the A. And it doesn't have to be a big hearing loss. It can be, you know, not being able to hear a whisper across a small, quiet room. And one study did find that hearing aid use was positively associated with improved cognitive functioning. The jury's still out a little bit on that, but why not? I mean, hearing is usually pretty easy to correct. And I think this is really interesting too. Reduction in hearing loss was associated with an age difference in the brain of about 7 years. So meaning if you have a small hearing loss, it's like your brain is 7 years older. This is what I was looking for. So this is that shows the attributes for dementia. So about 35% of dementias are potentially modifiable. About 65% we don't have a lot of control over. And frankly, there are some of these that we don't have a lot of control over anyway, because, you know, by the time we meet our people, we can't have them go back and get more education as youngsters in their early life. We can encourage them to take classes or join a book club. That's important. And that social isolation, again, accounts for about 2% of the potential modifiable risk factors for dementia. But here's hearing loss, huge. And that's usually where I put my money right away. Hypertension, obesity are big, smoking, depression. Physical activity is big too. So I'll tell people, get to it. 4 to 5 times a week, 45 minutes, break a sweat. If they are somehow have balance troubles or pain, I refer them to a physical therapist right away and get them going. Has anybody used a pocket talker? Yay, great, good. So pocket talker is this little handy thing. It's really just this size, and it has headphones. And I use it in clinic so people can hear me. And all it does is amplify. It doesn't do anything fancy. It's about $120. And for some of my people with dementia, it's kind of what they can handle. You know, those teeny tiny little hearing aids that fall out. Sometimes those just don't work, but a pocket talker can be very helpful and can really help engage families. We used it with my dad. His hearing was horrible, and he had diabetes, so he had really hard time with the hearing aids. He dropped 2 of them, and each one was eaten by my sister's dog. It's the most expensive dog in the county. But we got the pocket talker, and life just got a lot better. So I recommend using a pocket talker if hearing aids don't work. Exercise. Remember earlier we talked about hippocampal shrinkage? This study found that exercise actually increases hippocampal volume, which is critical. And it is. It's big. If you go to the Alzheimer's Association International Conference, you'll see a lot of big presentations about exercise because it's something people can do. We have control over it, and it is helpful. That, by the way, is in LA this year. If you want to know more about it, come find me. It's a great conference. Tai Chi is another great form of exercise. It's shown to improve cognitive functioning for a variety of reasons listed here. And then leisure activity is really important too. This study found that there was a reduced risk of dementia for people who engaged in leisure activities. It should be something that people enjoy. So oftentimes people will come to me and say, well, I've got these brain games that I play on my computer, but I just hate it. And then don't do it. If you hate it, don't do it. You need to do things you really like. So, for example, if that means spending time with the grandkids or playing Scrabble or going to a show, great. If you're an introvert and want to be home and alone and you enjoy it and you want to read your book, terrific. Just make sure what you do is enjoyable. Has anybody seen these pianos around Portland? This is the other thing that I do is I tell people, you know, if you played the trumpet in high school, pull that out again. Music is very powerful. I have several people in my clinic who have very advanced dementia, but they can still sing a hymn. And usually that muscle memory, somehow the music really taps into a deep memory. These come out in the summer. You'll see them scattered all over Portland, Pioneer Square. We do have one at the bottom of the tram. And you encourage people to find one and sit down and play. It really engages the community. Or play it at home. So we talked about sleep. I'm going to move fairly quickly because I want to leave time for conversation between us. But we know that there's a risk of MCI for people who get less than 6.5 hours of sleep at night or are really sleepy during the day. Limited risk is insomnia, and naps are protective. Yay! As we get older, sleep can be somewhat frayed, and that's normal. It's normal in an older person to feel less rested. So when people come to you and say, I just cannot get 8 solid hours of sleep at night, can you give me something? No, don't. That's not normal to get 8 solid hours in an older person. It's okay to be fragmented, and it's okay to take a nap. Tell them to take a nap during the day. We'll talk about that in a minute. We also know people who have sleep apnea are a much higher risk for dementia, so that's one of the things that we do right away in our initial evaluation is if we get any hint that there's some sleep apnea, snoring, restlessness, stopping breathing, we get them to the sleep disordered clinic. If they have a large neck circumference, you know, this is a CPAP machine. Some of my people with dementia can't handle these. And so, you know, that's just the reality. The good news is there are now oral devices, kind of like what you use so you don't grind your teeth, but they're specific to move the jaw just a smidge so you don't have apnea. Some people can tolerate that if they don't tolerate the CPAP machine. These medications are not safer. We try to avoid these in our work, and I'm sure you do too. Anything with diphenhydramine or something with a strong cholinergic is going to increase the risk of memory problems. So if you have somebody come in and says, I just can't sleep, please don't tell them to take a Benadryl. They're anticholinergics. When we attempt to treat dementia with these medications like Aricept, or Exelon, rivastigmine, donepezil, we're trying to increase the amount of available choline in the brain so the nerves can talk to each other. These are anti-choline, and they can really interfere with cognition. So please avoid these. Instead, I recommend starting with some melatonin. That has been proven to be helpful. But go through all those classic sleep hygiene things that you already do. No coffee, avoid alcohol, exercise, exercise, exercise. If none of that works, go to get a sleep assessment. We also have to be careful about the Z drugs. Zonada, and I'm going to get in so much trouble for using the brand names, but you know, Ambien, those guys, those as well as the benzodiazepines. There's a risk for cognitive impairment. The good news is the risk decreases when you discontinue that medication. So do avoid those. I mean, every once in a while if you're traveling, sure, but not on a daily basis. That's just not safe. And then for your people who are having trouble sleeping, despite everything you've done, you can also, including morning bright light therapy. The research on this is really interesting. Have them buy a blue light 1 hour in the morning, kind of off to the side, and get that stimulation for the suprachiasmatic nucleus. Okay, so brain shrinkage is normal, but it's more so with people, it's abnormal in people with Alzheimer's disease. make sure that you diagnose either as MCI or dementia to help these people out. Before people come into your clinic to talk about memory trouble, put them to work. Make the families do the work for you. Have them fill out the 88. Have them document situations where they're worried. And then address things. Address the main risk factors. Send them to get a hearing assessment. Make sure they see physical therapy or start an exercise program and assess their sleep. And then send them to us so that we can get them in a study. Even though we may have a wait list for classic clinic evaluations, if a person that you're working with has a memory disorder or is worried and wants to be in a study, those people we can get in right away. And that all they do is just call the number on this flyer. If you want to know more, I got some funding to do an ECHO project where we work with primary care physicians on diagnosing dementia. This flyer is out front for you if you're interested. We have a second session starting up in April, so you're most welcome to join us. That's all by telehealth, so you can do that from your home or your office. Okay, so let's chat. Questions, thoughts, observations? Yes, sir.
Well, question regarding the normal aging.
Mm-hmm.
Is there any difference in different ethnic groups?
Mm-hmm.
Or people living at high elevation versus low elevation? People on different diet like Eskimo or Mediterranean diet?
Okay. Let me see if I can handle this. Okay, so first of all, are there racial differences in prevalence of dementia? Are there differences in diet? And are there differences in elevation? So if somebody lives at high altitude, are they higher or lower risk?
And different groups.
Different groups.
For example, Asian versus...
Yeah. We know that African Americans are at much higher risk for developing Alzheimer's. There's a study that just came out yesterday that indicates that there's some cellular basis for that. And honestly, I didn't read that paper, so I can't really speak to it. But we do know that these folks are at higher risk, and we need to take that seriously. Elevation or altitude, I don't know. We do know that people who follow a Mediterranean diet, there is lower risk of dementia for people, olive oil, fish, nuts, a low meat intake. Yes. Hi.
When you were talking, I was looking at the MOCA test website, and the first sentence is that there is a lot of interest since President Trump passed the test.
Yeah.
But my question is, what's the sensitivity and specificity of that test?
Oh, shoot, that's a good question. I wish I had the answer at my fingertips. Anybody know the sensitivity and specificity of the MOCA? It's good. I don't have the exact number, in the 80s to 90s. Now, remember, this is a cognitive test. It just tests, it's not a psychiatric exam. So I'll stop there. And there's the MMSE and there's the slums. You can also use those. We just always use the MOCA.
You mentioned your APPV study. Are there not other studies looking at monoclonal antibodies to amyloid, and have the results not been disappointing?
Yes, you're right. So the APPV study is a monoclonal antibody study. It's a newer one. And the question is, haven't the other monoclonal antibody studies results been disappointing? And the answer is yes. The previous monoclonal antibody studies we used were with people who had dementia. And it reduced the amyloid burden, but it didn't improve function and it didn't improve memory. What APPV is doing is we're getting people who have normal cognitive function, and we're doing a scan at the get-go. If we see a high amyloid burden, we try to get those people in the study. If we see a low burden, they don't qualify. So if you know of anybody that's interested, I think the study entry is at age 60, we'd love to see you. It's a little bit difficult to recruit for because people usually, it's not on their radar. But we know what we're hoping is if we can get at the amyloid and reduce it before memory symptoms show up, that would be our treatment of choice. Good question. Let me get somebody else first. Yeah.
Any
tips on monitoring the progress once you've started one of the mediocre medications for Alzheimer's disease?
Yeah, I didn't even talk about the meds, did I? Any tips for monitoring progress after you've started the medications? So we have a couple of medications. We have donepezil, we have rivastigmine, we have galantamine, and memantine. The last drug that was invented for Alzheimer's disease was in 2003. So we don't have a lot of great options. When I start people on these drugs, I say to them, please don't have any expectations. Don't expect the memory to get better. What we're going after is trying to stabilize as much as we can the memory and maintain function for as long as possible. People will often come in to me a couple months later and say, well, it didn't really help the memory, so I stopped it. Well, that's not really the point of those drugs. Every once in a blue moon, I do have somebody who it does help their memory, but mostly it doesn't. What I do is I double check and make sure they're not having GI side effects. Because sometimes people will get diarrhea and they won't call me, they won't tell me. And they'll have diarrhea for months. So now when I start people on donepezil, I have them come back in about a month just to make darn sure. And if they do have the diarrhea or the stomach upset, I start them on the rivastigmine patch. And they usually do pretty well with that. The people that do tend to do a little bit better are the people with dementia of Lewy bodies. Those people, it does seem to help. The rivastigmine can be quite helpful sometimes. But you're right, the drugs are mediocre. Yes, hi. Thanks for coming.
Two things. So specificity in the MOCA, 90% for MCI, 100% in mild AD, 100%. Specificity
Wow.
for MOCA is 87%.
Okay, great. Thank you.
And I would just add to your last answer, which is the dementia-specific medications, cholinesterase inhibitors and memantine. I recommend following behaviors, the neuropsychiatric inventory, because that's actually where the money is as far as those medications. They prevent and decrease behavior disturbance, which is probably 100% in people who have Alzheimer's disease.
Thank you. Thank you. I really appreciate that. And that's an excellent point. If we can see improvement in behaviors, pacing, agitation, in Lewy body hallucinations, that's really helpful. And there is what we call a neuropsych inventory. I can give that information to Stephanie if you want access to that. Yeah.
How often do you see so many people in this population are on multiple medications with multiple side effects, which are often confusion, et cetera. And as people age, your ability to detox things slows down. How often do you see dosage change or this being, it's really hard to tease apart what's a medication combined burden side effect and what's dementia? Can you comment on that?
Yeah, I'd love to. How often do we know that it's like the polypharmacy that's causing the problem as opposed to actual dementia? And we're pretty lucky in that by the time people get to us, people have usually figured out that they need to prune the med list, but we still see it. And you're right, that's kind of one of the first targets we go after is, you know, why are you on daily lorazepam? Or, you know, try to get at the real heavy hitters first. Why do you take Ambien every night? Why are you taking 4 different medications for your blood pressure? You know, we tend to go at that pretty early in the game, and I do see that fairly commonly. I saw a gentleman with Parkinson's dementia just the other day who keeps passing out, and he was on diltiazem, metoprolol, and Lasix. So it's just like, and I'm not a cardiologist, so you know there are probably maybe good reasons for that, but they're not going to serve him well if he's on the floor. So it's a challenge for sure. Yeah.
Just a couple of things. First of all, you didn't mention B12, which I've used to cure amazingly dementia in several patients over the years. The other issue is one of blood pressure because, you know, as you say, the cardiologists protect the heart by getting the blood pressure so low that it doesn't support the brain. And how, I mean, as an internist, I'm constantly raising blood pressures.
Yeah.
And
I am too.
and I don't know how to kind of fight that battle, because I think that it seems like the cardiologists have a little more power than the internists and the neurologists.
So the question is B12. How often do I see it, and how often does it help? And then blood pressure. We see lower B12 levels fairly frequently. I haven't been lucky enough to cure somebody with B12 supplementation yet, but yes, of course you should if the B12 low levels, and even if they're kind of normal low, treat it. Wouldn't you agree? I don't know. Yes. Yeah, okay. The blood pressure question. Yeah, I tend to look at what the American Geriatric Society recommends for blood pressure control for older adults and go by that. And I use the little Geriatrics at Your Fingertips book every time to make sure I've got it right. But I also have a conversation with people about their quality of life goals. So if they are feeling, what is most important to them. If they're feeling a little lightheaded, but their cardiologist insists that this is going to extend their life and they really want to do that, then that might be their path. But what I would recommend I agree with you, is float the blood pressure a little higher so you're not feeling dizzy.
I guess the other question is about circulation. Yeah. Aspirin, Plavix, newer anticoagulants. That's
well, for people who are at high stroke risk, absolutely, we do need to address that. We didn't even touch on vascular dementia, but yes, absolutely, if they're at high stroke risk, you absolutely need to hit that hard. Yes.
Great talk.
Oh, thank you.
Oregon has a really high suicide rate, particularly in over 65 populations. Can you talk about the associations and studies with suicide, cognitive dysfunction, and can you also talk about some kind of practical things you do in your clinic to kind of screen for suicidal thinking?
Yeah, thank you. So the question is high rates of suicide in adults over age 65 in Oregon and across the nation. How often do I see that in my population, and how do I screen for it? Those are great questions. I usually, if the subject comes up around depression, we talk about it. If I do a depression screen, or if there's some red flag, I just say, are you thinking about killing yourself? And I ask that question fairly often, so I'm pretty comfortable with it. And I also find it really interesting what people say, don't you? Yeah. And I have had 2 people over the last year who did receive an Alzheimer's diagnosis and wanted to end their life. It wasn't so much that they wanted to off themselves right now, but they just didn't want to live with dementia. And so they had very specific questions of, how do I withhold food and fluid, and can you provide me the death with dignity medication? Now, I can't. I'm a nurse practitioner, so I can't. And with Alzheimer's disease, with death with dignity, you have to be within 6 months of death, and you have to be cogent. So that leaves Alzheimer's out of the picture. You can do withholding food and fluid. The website Compassion and Choices has guidelines on how to withhold food and fluid. So I'll send them there. But of course, if they're actively suicidal, that's where you get them into care right away. But if it's a depression without active suicide, we get the depression treatment going fairly quickly. I'm pretty lucky in that we have a geriatric psychiatrist on our team, so I can run down the hall and say, ah, but that's a whole talk in itself, isn't it? I mean, it's a huge issue. And I find when I sit down, when people say, I really want to kill myself, I find it's really helpful to just sit and talk with them, because it's a valid concern. Okay, well, that's it. Thank you for your attention and your questions, and let us know if you want to join us. Oh, a true pleasure. Oh, thank you. Well, I hope it was helpful. Yeah.